Here's case 7 for EMT. Prereqs on this include all the usual routing and response planning and assessment stuff, and then we add in awareness of OBGYN emergencies, including childbirth and newly born care, and that whole large, huge topic of how do you deal with those situations, and a whole bunch of different terminology than we use every day. So there's gestational age, there's EDD, amniotic fluid, amniotic sac, meaning did my water break, are my membranes intact, that sort of stuff. What is gravida, para, aborta, preeclampsia, eclampsia, what do you do about umbilical cords if they're prolapsed or presenting a nuchal cord? So here the call is, time of day is 3 o'clock in the morning, your 3-minute response time. The transporting medics are 5 minutes behind you. You've got 12 minutes to any of 2 or 3 different directions, including an OB specialty center. You're a BLS first response unit. You're dispatched for a childbirth at the Greyhound bus stop. And the address at the time was 6401 Highway 40. Cunningham and Ivy are the cross streets. Your response is lights and siren. It's very short. It's the middle of the night. You can run right up the street. And this is a location that you go to quite often for various types of calls. On the way, you have a little bit of time to run through childbirth in your mind. The big keys are determine if the delivery is imminent, prepare for that emergent delivery, and then what if that baby's really sick? What are your resuscitation points going to be on that? Then you've got other OBGYN issues to think about. Is there bleeding? Is there eclampsia or preeclampsia? And so other than it being 3 a.m. at the truck stop, there's no obvious safety issues other than body substances. And we know that body substances and childbirth go together, and there are lots of them. Here's the scene info. This would be from 3 o'clock in the afternoon. This is what it looks like at 3 in the afternoon. And, uneven parking lot, cars around, and this is a travel plaza at the Midway exit, which is also serving as a bus stop. The patient's alert. She's walking. She says she's in labor. She needs to go to the hospital. She has a very strong radial pulse at a normal rate, maybe a little bit up, but not, crazy fast. Her skin's normal. She's breathing okay, not contracting. The only problem with breathing is when she is contracting. No cyanosis. Urgent action. Well, let's get you set down somewhere. If you had an ambulance, you'd get her in the ambulance. And you need to figure out if delivery is imminent. And the only way to do that for sure may be to look for crowning. But you ask her, do you have the urge to push? Is this your first baby? These kinds of things. You're asking, do you know what you're doing with this? Because in many cases, folks, it's straightforward to say this. If the patient's had babies before, they probably know more about themselves and having babies than you do. And so ask them, are you crowning? Do you have the urge to push? Is this your first baby, which would indicate a fairly long labor, or if this is your 5th baby, then a pretty short labor. And, they call for various reasons. Did this girl call for a ride to the hospital? Or did she call because she needed help because she thought she was about to deliver this baby? Then, for urgent actions also, find your OB kit and find a place to deliver it. And we're just going to set up and be ready. And the moment that she starts really urge to push and really frequent, strong contractions and you detect crowning, you got to get that OB kit open and get ready for a crash delivery. So in the meantime, we're going to gather some data and info, get a pressure, heart rate, breathing rate. None of this seems out of line. O2 therapy, none indicated at this point. What about this? Well, she had a miscarriage and now she's in her 2nd pregnancy, but she's 2 months away. Think she's at about 31 weeks, which should tell you that's pretty early. That baby's going to be very likely to be very small and more likely to need resuscitation than if she was at 39 weeks. She's contracting every 5 or 6 minutes. It's fairly strong, fairly regular, and her, in quotes, water broke. Her amniotic sac ruptured, her amniotic membrane ruptured at the time of the call, she believes. And they're usually right, although there are some cases where it was just urinary incontinence. But you kind of got to believe her at this point. And so she thinks she's getting ready to deliver, but maybe not right this second. She thinks it's going to happen pretty soon. She's on some vitamins and has had some prenatal care at home. She's on the bus down from Chicago, and they've been screening her for high blood pressure and swelling and glucose problems, and she's not had any issues. So really no high-risk pregnancy here, and some, if not good, prenatal care. Her abdomen is as you would expect it to be for a 31-week along. Other than that, her physical exam is unremarkable. And so really, what are you going to do? Your plan here is to be ready in case she delivers. But other than that, we're going to just check her vitals and wait for the ambulance. And that's totally reasonable as long as you're also ready. So this would be a pretty good handoff. You can stop it and look at it some more if you want. This would be a pretty good inbound report. Again, let's make sure we use medical terminology appropriately, and we are concise, and we are brief, and we speak at a speed at which we can be understood. That is fast enough not to be infuriating to the person taking the report, but slow enough to be understood. And let's give a handoff to the ER, where we introduce her, give a little bit more background, and kind of fill things in. And then, so how did this go? And here's your written report, which you can pause and look at if you would like. How did I do? How did my team respond to me? How did my communication go? Did I inspire confidence in this patient that I knew what I was doing even if I was scared? And then some other questions. How do you know if delivery is imminent? How do you handle that delivery? How do you manage that newborn if they're not sick? How do you manage them if they are sick? And then what about some of these terms? Is she preeclamptic? What is eclampsia? What if there was vag bleeding along with this? And so this case is just kind of a starter point for us to jump off and discuss a whole bunch of this OBGYN stuff as part of Case 7.